Thank you, sir, for an enlightening talk. Professor Shafi and Dr. Khurshid Hassan Saab, if you're here, can you please join us on the panel of experts, sir? I will now invite our next speaker, Dr. Osman Faheem, who will talk about hemodynamic support devices in high-risk PCI and cardiogenic shock. Dr. Osman is serving as an assistant professor, section of cardiology, Department of Medicine, director, structural heart disease, Aga Khan University, Karachi. Sir, please take over.
Assalamu alaikum, everyone. Thank you for giving me the opportunity to present on this topic. We'll jump right into it. So I've been asked to talk about hemodynamic support for support devices in high-risk PCI and cardiogenic shock. These are my disclosures. So basically, I think it's important to understand what's high risk and what's shock. So there's different criteria, but high-risk PCI is, according to some data, is called unprotected left main or a PCI on the last remaining vessel, whether that's native or graft, EF less than 35%, or complex three-vessel disease with comorbidities, which include severe AS, severe MR, shock, arrhythmias, or pulmonary hypertension. You can break them up into clinical criteria, comorbidities, and anatomical procedural criteria. So under clinical, you would have severe LV dysfunction, decompensated heart failure, active acute arrhythmias. With comorbidities, you have valvular disease, severe lung disease, GFR less than 30, and acute coronary syndromes. And under anatomical and procedural, you would have unprotected left main or its equivalent, three-vessel disease, high syntax score, or retrograde CTO. So those are two of the main criteria that's followed. For shock, the clinical criteria is hypertension with a systolic pressure of less than 90 for at least 30 minutes, or need for inotropic support to keep it above 90, or evidence for end organ perfusion with low urine output, etc. And hemodynamic criteria is low cardiac index less than 2.2, or wedge pressure greater than equal to 15. So basically, to have a successful outcome for these complex cases, the steps actually start before the patient is in the cath lab. So initially, you have to make sure you see the patient yourself, assess them clinically, see what their volume status is, see if there's any factors that would affect a good outcome of your procedure, because you don't want to find those out while you're in the middle of the case in the cath lab. Always look at their mentation, see what sort of sedation you'll have, do you need anesthesia there or not. Review their labs, look for anemia, electrolytes, check their renal function, because that's all going to go into your planning, how long you can keep the patient sedated, and how long you can subject them to a complex case. Assess their volume status, think about your access, whether you're going to go radial, bilateral radial, brachial, femoral, what your sheet size is going to be, so plan all of that in advance. And right heart catheterization is something you should especially think about in some of these cases, because the data may surprise you. And there's two things that I'm going to point out which I find very helpful. So cardiac power output is coming out to be more and more as an important factor when you do a right heart cath. And it's one of the strongest predictors of mortality in cardiogenic shock. It's very easy to calculate. It's your mean arterial pressure into cardiac output. And so if that is less than 0.5, that's the 451 is a typo. If it's less than 0.5, then that's a strong predictor, and you should be very seriously thinking about support for that case. So less than 0.53 is a strong predictor. And then PAPI index in cases of IMI or inferior myocardial infarction, it's again simple to calculate. It's your systolic PA minus the diastolic divided by the right atrial pressure. And that gives you, if it's less than 1, there's different criteria for different situations, but less than 1 in IMI is predictor of poor outcome, and you should think really about how you're going to go about that case and take it to a successful outcome. So basically, we've come down to 4 percutaneous devices for MCS support, whether it's shock or high-risk PCI. There's balloon pumps, there's Impella, tandem heart, which is used less and less due to its complexity, and ECMO, which may be a VV ECMO or VA ECMO, depending on the circuit. I'll talk more about balloon pumps and Impella because that's mostly what we have access to. I think 99% balloon pump and some Impella here and there. So mechanism is balloon pumps in the aorta, whereas Impella unloads LV to aorta, tandem heart, LA to aorta, and ECMO RA to the aorta. Flow is different, very little flow support for the balloon pump, whereas greater than 4.5 up to 7 liter support for ECMO. Balloon pump is the easiest to put in because of sheet size and access, and the sheet size progressively goes up as devices get larger and up to 21 and 22 French for your ECMO circuits. For your cardiac power, balloon pump augments it the least, and then the Impella can get up to, the percutaneous CP Impella can get up to 4 liters per minute, ECMO can get up to 7 liters per minute. Balloon pumps and Impella increase your coronary flow, but tandem heart and ECMO will not. They basically unload the left ventricle and provide circulation. Balloon pump will reduce your afterload. Impella, maybe not so much. And tandem heart and ECMO actually have retrograde aortic filling, so you will increase your afterload. And all of them either reduce myocardial oxygen demand or don't affect it much at all. So we're all familiar with balloon pumps. It sits in the aorta, distal to the left subclavian, comes in different sizes based on the patient's height. So it basically facilitates cardiac filling of the aorta as it deflates during systole, reduces myocardial work and oxygen demand, decreases end-diastolic, aortic, and systolic blood pressures of up to 30 and 10%, respectively, which is why a lot of times you'll see that the mean arterial pressure goes up, but the systolic will actually go down on these patients. There's a modest increase in cardiac index, not really one of its strong features, and it requires a basal level of LV function and stable electrical rhythm. AFib in the heart rate in the 130s, the balloon pump is not going to work, or a really erratic rhythm, the balloon pump will not work, and it requires some sort of EF. It's not, since it's sitting outside the LV. You know, one of the earliest papers was in 1999. The device has been around since for about 4 decades, but this looked at 300 patients with acute MI and cardiogenic shock, and early versus delayed revascularization. 86% of these patients had balloon pump in both arms, and the primary endpoint was all-cause mortality at 30 days, and the secondary endpoint was 6-month survival. 30 days, there was no difference, but with early invasive, 6 and 12-month mortality was lower, and that's where a lot of the idea that balloon pumps should be put in for acute MIs came about. This led to the SHOCK 2 trial. All of us are very familiar with this. It's one of the landmark cardiology trials. So 600 patients were randomized to either balloon pump or no balloon pump. 30 days, there was no difference in mortality. And in terms of secondary output, secondary endpoints, there was not major difference at all. Lots of criticism for this based on sample size calculation, as well as crossover between patients who were assigned to the balloon pump arm versus the Impella arm. And even in the per protocol analysis, there wasn't anything significant. So also the BCIS-1 trial, it was a prospective multi-center randomized controlled trial, EF less than 30%, and again, in-hospital MACE with balloon pump was no different. 12% required rescue balloon pump, but late benefit, 51 months mortality was lower in the balloon pump group. I'm going to skip this and move on to Impellas. So basically, this is a device that's put in transfemorally or axially. It goes from anywhere from 13 French to 21 French and up to 5 liters of support, unloads the LV to the AO. It is preload dependent, so you need to give fluid boluses and have to have normal RV function, and appropriate LV position is essential. If it moves, you can tangle in the mitral valve apparatus, have ventricular arrhythmias, and hemolysis. The PROTECT 2 trial was the major trial comparing balloon pump to Impella. I won't go into the details in the interest of time, but basically there was no difference between balloon pumps and Impella. The PROTECT 3 trial was a single-arm registry and basically showed that it was safe without major complications to put in. I'm going to skip that as well because this was also a negative trial. And then US Pella registry was a real-world look at patients who had Impellas put in, 127 patients for unprotected left main who underwent high-risk PCI, 71% men, EF was about 28% on average. Syntax score was 31 pre-PCI, 7.86 post-PCI, so good revascularization. And it was basically showing that for high-risk PCI, the Impella was safe to use. Things that favor balloon pump is short implantation time, reduced chance of limb ischemia, reduced chance of vascular complication, hemolysis, can stay in for about 7 days. Contraindications are moderate aortic regurgitation. For Impella, all of these take longer to put in, and it can't generally stay in as long as a balloon pump. If you look at the 2015 consensus statement, it reflects the data. Mechanical circulatory support devices may be considered for patients undergoing high-risk PCI. Early placement of MCS may be considered in cardiogenic shock patients who don't respond to therapy. Balloon pump is less likely to provide benefit in cardiogenic shock than continuous flow pumps, and there's insufficient data to support or refute the routine use of MCS devices, and more data is urgently needed. So in conclusion, cardiogenic shock and complex high-risk PCI are associated with a high incidence of morbidity and mortality. Their newer devices, percutaneous MCS devices, have evolved dramatically and have the potential to improve outcomes. However, ICs need to understand indications, contraindications, device placement, monitoring techniques, and device selection. And despite advances, randomized controlled trials haven't shown conclusive improvement in hard outcomes, and further data is needed. Thank you.
Thank you, sir. Before we move on, Professor Saqib Shafi Saab and Dr. Farhan Taib, if you're here, can you please join us on the panel of experts, please? Precision medicine is the new paradigm and is focused on the needs of an individual patient. It relies on biological, mechanical, and personal variables to optimize individual therapy. Examples of precision